I am Anna Seawold, and this is Authentic Parenting, a podcast about growing ourselves while raising our children. I'm a psychologist, educator, and parent coach. And on this podcast, we explore how you can connect to your authentic self, practice radical self-care, and raise emotionally healthy children. Let's break the cycle of generational trauma for a more peaceful, kind, and compassionate world. Today, are we overdiagnosing our kids, rethinking ADHD, autism, and the search for normal?
Hello, I'm Sami Tamimi. I'm a child and adolescent psychiatrist and psychotherapist and author. And I've recently authored and had published a new book by the title of Searching for Normal. And you're listening to the Authentic Parenting podcast.
Today's episode is a provocative conversation. What is mental health? What is a diagnosis? Are ADHD and autism genetic? What happens to families when every struggle gets a label? Why do we see such increased rates of mental health disorders? Are we helping children or turning normal struggles into lifelong diagnosis? Dr. Tamimi challenges many widely held assumptions about children's distress, resilience, and the role of experts. You may not agree with everything you hear, but if you're willing to stay open and curious, you'll gain a radically different lens on big emotions, learn how to support children without immediately turning them into patients, and discover ways to nurture resilience and confidence in everyday life. Please enjoy, and thank you for listening. I love the cover of this book, Searching for Normal. What is normal, right? Reminds me of The Myth of Normal by Gabor Mate, who I interviewed on the podcast. And I saw that you reference him in the book. So what makes you so passionate about this topic? Number one, tell me a little bit what drives you.
There are many things, but I've been a child and adolescent psychiatrist for over 3 decades now. And I consider myself really a traditional child and adolescent psychiatrist. Because when I first encountered child and adolescent psychiatry back in 1992, the predominant way of thinking about and trying to understand the young people who presented to us was centered around a understanding and appreciation of context. So a systemic approach was quite central, and that basically is an understanding that people, and children in particular, are surrounded by a social context. And of course, with children, many of the important decisions in their life are not taken by them. They're taken by adults in various caring relationships around them, which means not only understanding their context, but also understanding the resource in terms of helping them is from the people who are around them, from the important relationships. So that was one of the important things that I felt when I first encountered child psychiatry. We saw people with their family. We didn't even talk about patients. We talked about the identified patient. In other words, this is the person who's brought forward a particular issue, but it doesn't necessarily mean that helping people with this issue is by fixing something internal to the child. And it also meant that you shouldn't ignore the resources around that child in terms of helping them. So that systemic perspective was very central. And the other thing that was very central was a developmental perspective, which means an understanding that as we go through life, things change. And of course, that's particularly true for children. Their body change, their interests will change, the way they experience their emotions, their relationships, all sorts of things are going to change as they grow. So a understanding that you shouldn't be in the process of trying to fix an idea that they've got something lifelong and unchangeable. So this is where I came from. This is the orientation that made sense to me. It's a very culture-rich orientation as well. But so that's why I went into child psychiatry. To become a psychiatrist, first you have to train as a doctor, then you train as a psychiatrist, and then you specialize. And my experience in adult psychiatry felt like most of adult psychiatry was a bit like being a glorified pharmacist. I didn't see much examples of people actually understanding and looking for a more holistic idea and holistic understanding of the types of challenges that people were facing. But what I've seen in the years since then is a creeping medicalization of that field, and in a way that has undermined these very concepts that I felt were not just important for me as a child psychiatrist, but actually I felt they were the kind of gift to the rest of psychiatry and indeed the rest of medicine, that understanding of the importance of context and development. And what I've seen happen since then is that there has been a colonization, if I can put it in those terms, of concepts that turn these more holistic ways of approaching a problem into an idea that there's something going on in the child. So a search for an idea that there's something abnormal, there's something broken, there's something dysfunctional, dysregulated, choose your favorite word, that is happening in the child. And so that our approaches became more and more about fixing something in the child. And I see now that we have a generation in this country, I suspect it's very similar in your country, probably even worse, who are more pathologized than any generation that I've grown up around. So we have a generation growing up whose carers and who themselves have been led by a narrative which is shaping people to become suspicious of their emotional reactions and suspicious of the idea that they may be developing a mental health problem, and a rush towards diagnosing that as if it's a medical diagnosis, and a rush towards various types of, if you like, technological approaches rather than holistic approaches to fixing something that is assumed to be within the child. And all the evidence is, and this connects with my clinical evidence, but I've tried to outline in the book the actual research evidence, that this is associated with deteriorating outcomes. So this approach has not led to improved outcomes. It's not led to a decrease in the suffering or a decrease in the experiences of mental health problems. It seems to have led to the opposite. And so it feels really important to me as somebody who came into this profession in the hope that I can be a little bit a part of some people's lives in helping them get through a particular difficult moment in their growing up years and get out of the mental health system and just get on with their lives. But we seem to have developed a system that seems to be capturing more and more people into that system with the idea that they have some lifelong diagnosis and becoming potentially consumers for life and becoming long-term patients. And that's the opposite of what I think my profession should be doing.
Hey, I want to invite you to a new adventure. In the world of quick texts and emojis, so much remains unsaid and unprocessed. But when we sit down and write a letter, it helps the thoughts and feelings we've been carrying finally have a voice. Letters have been part of my life for as long as I can remember. I have written many. I use them in my work, and I know how powerful they can be for healing, whether you send them or not. That's why I created a year of letters on Substack. Each week, I share a gentle prompt inviting you to write a letter to yourself, to someone from your past, to an emotion, or to a part of your life that wants attention. We also offer occasional guest sessions and community reflections. You can join anytime, write at your own pace, and leave whenever you need. Join me on Substack, A Year of Letters with Anna Seewald. I would love to write alongside you. So much has changed, since the time you practiced first psychiatry and when I first became a psychologist, the terms were different too. I used to work in a correctional facility when I first graduated, and the term we used at that time was emotionally and behaviorally disturbed children. That's no longer in use. We see newer terms emerge, right? PDA, pathological demand avoidance.
That came from a city near where I live. That came from a professor in Nottingham. Yeah.
That came from the 80s, right? I did a little digging, but it's having a moment right now. In fact, and there are so many internet people, right? Moms, regular moms, professionals, non-professionals, handing out advice or sharing their own journey. Yesterday, I stumbled upon this mom, I think. I don't know if she's a professional or not, but she's dishing out very dangerous information. So the term she used to describe her son is, and I saved it, I can play it for you. She says, "My son has a nervous system disability." And I said, wait a second, what's going on? So everybody is talking about almost everybody has ADHD, adults and children alike. In my practice, what I see is parents ask me for referrals for child psychologists for their 3-year-old. As young as 3, they want to put their children in therapy. 3, 5, 6-year-olds, they put in therapy. And as a parent coach, what I'm noticing these days is this trend. Remember the helicopter parenting trend where parents were like overly involved? What I'm noticing as someone who works with parents is this hands-off parenting now, where parents are too busy and distracted by their devices and their phones and pulled into millions of directions. So are the children. And when parents talk about parenting, they want their children to definitely have a diagnosis, to be medicated, and to go to therapy. This is a big trend I am noticing in the United States right now. And if you don't go to therapy, well, there's something wrong with you. It's becoming more and more commonplace. And so I want you to comment on those things that I said, and then we'll dig into your work. What is mental health? What is a diagnosis? And so on and so forth.
Well, they're very connected to the things that I've written about. And I think that those observations are the almost inevitable outcome. So I can't blame parents for imagining that their young have these various conditions that require some sort of expert to identify, because this is the narrative that has seeped out into the public sphere. And the narrative sadly comes from people in my profession. It largely comes from sections of academic psychiatry. Not all of psychiatry agrees with this. I'm part of a network called the Critical Psychiatry Network. In fact, I'm one of the co-chairs of this. And we have hundreds of doctors actually who share similar concerns about what is going on, about this spread of ideas that just around the corner there are all these mental health conditions. And I guess big popular ones at the moment include things like ADHD and autism, and this spread of this idea that you have to identify them early. And if you don't identify them early, they're going to lead to they're going to lead to your children becoming criminals or never getting a job. In fact, the opposite seems to be true. The more so what's happening is we're kind of in a process of shifting our way of helping and managing young people's emotional development, shifting it as a task for professionals to do. So I call it cognitive parenting. There's a peculiar form of, we've graduated from the helicopter parenting, and there's probably still a lot of that about, into a form, an idea that has spread around. And again, I don't blame parents for this. They're just picking up on the things that we've been selling to them. So an idea has spread around where children are being approached as if they're young adults, as if they're already developed the capacity to think through. So you have a situation where parents are getting more and more concerned that if they intervene in any active way in a child's development, they could be damaging them. And that in order to bring up a child successfully, you need the input of experts, which kind of shifts the whole task of parenting away from something which centers around nurture, care, compassion, love, guidance, education, all of these things, into a technical process where your child is a product, and you have to build this product in a particular way if they're to be successful. And one of the messages that comes across is you don't know how to do the right way. You need an expert to tell you how to build this product successfully. And also, you're getting these messages that your child is very vulnerable to these 101 different conditions. And what it's making parents feel is very suspicious of when their child displays emotion. And it's also advertising a sense that if you don't intervene and get that expert help early, you are a neglectful parent. So there's all these messages going around, which is undermining the actual process of bringing up your child in a way that that has all of those things that build relationships. And instead, it's getting in between the relationship of a child and a parent, because they're becoming suspicious that they don't know how to handle. And these messages, of course, are internalized by the child as well. Once you go down the path of diagnosis, as they grow up, they've got this message, just like the situation you just described, that there's something about your nervous system that's not working properly. And that's why we needed to get this extra help. One of the worst ones is this PDA, this pathological demand avoidance.
I agree.
And I've seen, and what I've seen clinically, is just how dangerous this idea is. Because one of the messages that comes across from this ludicrous idea of pathological demand, that some kids have this, it starts with the word pathological. In other words, something's wrong. That some kids make demands and also avoid expectations. What kid doesn't do that, at least at some point? But what happens is that the message that comes to parents is that when they get overwhelmed, you shouldn't call it a tantrum. It's not just a protest. It is because they are sensorily overwhelmed, and therefore you should back off. So one of the prescriptions is don't make demands of your children. And I've seen children who've ended up in the physical health hospital because they were fussy eaters. I've had a fussy eater. Lots of children are fussy eaters. And when the child starts protesting about the parent wanting them to eat more, they back off because that's the advice they've been given. And they've ended up with a severe malnutrition to the point where they needed hospitalization. And working with these parents was almost just like giving them permission, and I've and I see the parents with the child, and not anything. You're not trying to create some sort of authoritarian nightmare for the child. You're trying to help empower the family to say, hang on a minute, this is dangerous. You should make some expectations. You can help your child. Don't be afraid of conflict. Conflict always happens with kids as they're growing up, because if a child finds themselves with too much power before they're developmentally ready, that's a very insecure position to be in. If you can't feel that your parents have some sort of backbone to hold you together and to hold your family together, and that you're kind of more in charge than they are.
That's cause for anxiety and depression and lifelong mental health right there.
Exactly.
Yeah, right there. You know what? There's zero tolerance for quote unquote bad behavior. There is a statistics in the United States. 50,000 of preschool children annually are being expelled and suspended from preschool.
Preschool.
Preschool. Why? Because of behavioral issues. I talk to conferences to young, at conferences to those professionals, and they want everyone to quote unquote behave, to sit still, normal behaviors that like a 3-4-year-old is developmentally unable to do yet. They lack the social skills, the emotional skills. Immediately a label is put on, or a referral, or they expel and suspend kids because there's no room if you are acting out, if you're aggressive, if you hit another kid with a toy, if you don't know how to take turns, and on and on. 50,000 children in the United States annually.
You've just given another great example of this trend towards viewing children as if they're not children, as if they're already capable of being adults and making logical decisions. I mean, it's just absurd. I mean, that's a terrible thing to do to kids. But I've seen this in this.
So, Dr. Tamimi, you're not saying that mental health doesn't exist. You're not saying ADHD is not real. You're not saying autism is not real. But what are you saying? Because there are people and children who do exhibit trait or characteristics or symptoms or whatever you want to call it, right? I know those families, I know those kids, and people feel empowered when they have a diagnosis. They finally, their life comes into sharp focus, or parents suddenly understand their children. And you write about that in your book with one particular child. You asked, I forgot the name of that, like 15-year-old, like, what would this diagnosis give you if you knew that you had this, like how your life would be different? And that child was going to college or something like that. So talk to me a little bit about that. Like, is this real? Like, because we see people who have, challenges.
Of course we see. So from my point of view, we need to make a distinction between the idea that distress, behavioral challenges, differences, of course they're real, but the framework in which we interpret the meaning and the significance of those experiences have very powerful effects, not just on the people around you, but on yourself in terms of how you then experience those feelings of distress, difference, etc., etc. So one way of distinguishing that is to say that the behaviors and the distress is real. However, the labels are not scientifically valid or supported. We are making big confusions when we imagine that what we call ADHD, for example, or what we have come to call autism, is a reflection of something that we know and understand and can measure, which is related to some abnormality that's specific or characteristic, or some difference that's specific and characteristic, that those with that label have compared to those people without that label. In other words, there is nothing specific going on in the brains and bodies that, at least so far, we've been able to identify that marks this group out. And therefore, what we end up with is constructs, because they are built around descriptions of certain behaviors or certain experiences, they become constructs that can be expanded in all sorts of different ways. In my book, what I try to do is to go back to examine some of the assumptions that have structured the way we think about mental health. And I start just with the concept of mental health to start with. So the concept, all definitions of mental health, I give several examples, they share one thing in common. And I've done this exercise with loads of different groups, from professional to lay, and asked them to try and come up with their best definition of mental health. And the thing that they all share in common is that they're subjective. They lack what is referred to as an empirical anchor. There's nothing measurable in the brains or bodies of the people who get these labels. And the consequence of that means we literally don't know what we're talking about when it comes to mental health. It's all in the eye of the beholder. And I also then interrogate the whole question of what we mean by a diagnosis. So a diagnosis is a system of classification. We have lots of systems of classification. A diagnosis is a system of classification that points to a proximal cause. So in a lot of the rest of medicine, and actually some of these problems are there in the rest of medicine too. It's not unique to psychiatry, but it's very visible in psychiatry. And it's one of the reasons why I think if we were doing psychiatry properly, we'd have a lot to offer the rest of medicine, which struggles with some of these. But unfortunately, largely because of commercial incentives, psychiatry is trying to pretend it's just like much of the rest of medicine. But in much of the rest of medicine, you don't see concepts with the word disorder after it, for a very good reason. Adding the word disorder after it is an attempt to make it look as if you're identifying something that is out of the ordinary, out of the healthy. So you don't get an asthma disorder, you don't get a diabetes disorder, you don't get a heart failure disorder, etc., etc. You get my point. And because in those bits of medicine, you can identify something external to the subjectivity of the person doing the diagnosis that is measurable. So in diabetes, you can measure the levels of blood sugar. And there might be debates about where to put the cutoff line, how often to measure, what to do, when to introduce medication as opposed to dietary, etc., etc. There's all of these technical, but you have a starting point to build caseness. You don't build caseness based on a description of the types of symptoms that some people with diabetes might have. So you don't build caseness around feeling thirsty, going to the toilet a lot, and fatigue, because a lot of people with diabetes don't present in that way. And a lot of other conditions might present in that way. And it might be just psychosomatic. You might not have anything wrong with you, but still feel those experiences. So you define diabetes by reference to blood sugar levels. So when you collect a group of people with high blood sugar levels, you have an empirical anchor. You have something to measure. But it also means you can now measure the effects of treatment. So you can see if your treatment reduces blood sugar or not. So you have the basis on which to build technical knowledge. The thing is about psychiatric, or what we call psychiatric diagnosis, is they don't have those features. But we treat them as if they do. And that ends up with you making some basic philosophical mistakes, which we're making left, right, and center. So when we define something like ADHD, how do you know somebody has ADHD? Because they're hyperactive and they show poor attention. How do you know the hyperactivity and poor attention is caused by ADHD? It's because they have hyperactivity and poor attention. The definition is based on a description. It's not diagnostic, but we treat it as if it's diagnostic. So when people wonder, why am I behaving like this? And you don't say, well, those behaviors describe, when you're doing those behaviors, you're describing ADHD behaviors, but when you're not doing those behaviors, you don't have ADHD, which is literally how you should approach it. You say it's caused by ADHD. So we treat it as if it's a diagnosis, but it isn't. It's just a description. And there are very few areas in psychiatry where we have these empirical anchors that enable us to build this technical knowledge. So learning difficulties is one which we know has a higher association with known genetic abnormalities and likelihood of some sort of neurological insult. And this is where we're getting into a lot of confusion, particularly with concepts like autism. Because the concept of autism first arose, of course, back in the Second World War. In 1943 was the first paper that was written which proposed the idea of autism. And that paper, of course, written by Leo Kanner, was referring to children. It was 11 children who he described as having a kind of aloneness in their experience of the world, but they all had moderate to severe learning difficulties. So originally autism, when it was first conceived and the early prevalence studies showed a prevalence of around between 1 and 4 per 10,000. And again, nearly all had significant learning disabilities. They also had a higher association of conditions like epilepsy, brain trauma, encephalitis, etc., etc. So the association between autism and an idea of something being physically compromised neurologically goes back a long way. But as it's expanded, because it turned into this spectrum referring to particular types of very increasingly common behaviors, it's gone well beyond that. So now we have the strange situation where the same label can be used for those who are not going to be able to live independent lives, may never develop speech, and may require 24-hour care and have lots of educational and social and clinical needs, right up to Elon Musk, the richest man in the world, who's also considered to have an autistic spectrum disorder. I mean, that's the full human spectrum of functioning. And so when that happens, you realize this is a construct which has no empirical anchor. It doesn't have a starting point in which you can gather a group of people and say, you have something essential, biological, in common, which can lead us to develop some technical knowledge about. And so that's what we're struggling with now. We're getting such a disparate group of people with such different needs, all coming under the same category, to the point where these categories no longer make any sense. They don't help us understand what your functional needs, what your social needs are, what your clinical needs are, what your educational needs are.
Say a few words about autism and it or ADHD being genetic, because people, say that, right? They say it's genetic, it runs in the family and all of that. Is that true? Is it debunked? Are there papers that establish that? The short answer is no.
The short answer is, and my prediction is that it's never going to be the case, because you don't have this starting point of an empirical anchor. You don't know, you don't have a place where you can gather a group of people who have something physical in common that you can measure that could allow you. This is why we have these huge spectrums developing. In my book, I take up a number of examples. So I look in particular at the research around ADHD and autism, which has been two of my interests over many decades. I've been following the research. I've been trying to track what's going on. And the idea of having a strong heritability, which has been the case with proposals for autism and ADHD, not only do they come from a different group of people, because we don't know anymore, because the spectrum of people who are getting the diagnosis is so wide now. If you take research from, just 10, 20 years ago, we don't know if we're having the same group of people at all as the ones. But even when you look at those research, the original ideas came from mainly twin studies. But the problem with so in twin studies, if you have identical twins, they're going to share 100% of the genes. And if you have non-identical, they'll share 50% of the genes on average. So if an identical twins end up with a condition more commonly than non-identical twins, this was assumed to be a evidence that this has a strong genetic component. Now that might work for some things, but when you're measuring behavioral and experiential characteristics, it is that method cannot distinguish between environmental and genetic because of something called the equal environment assumption. So the equal environment assumption means that you're assuming that identical twins will share the same environmental characteristics as non-identical if they're raised in the same family. But of course, that's not true. Identical twins swap identities with each other. They often put in the same clothes. They can be confused with each other, and they tend to have much closer relationships than non-identical twins. So there are all of these other psychosocial factors. So the only way really to get any evidence around genetics is to look at the molecular genetic level. And since the decoding of the whole genome, human genome, which now we've got studies go back 20, 25 years, and there are various methodologies, and I go through some of them. I try to make it as accessible as possible for people to understand these methodologies. Since we've been looking at the molecular genetics, and we've got huge banks now, tens of thousands of individuals who've got a diagnosis of autism, for example, or got a diagnosis of ADHD, and comparing that to tens of thousands who don't, they're struggling with an issue that is called the missing heritability. Why is it called the missing heritability? Because they assume there is heritability, but they can't seem to find it in the molecular genetics. The reason they can't find it, or the most likely reason, is that it isn't there. And it's never been there, because they're not comparing like with like. They're comparing a big spectrum of people with all sorts of differences. And therefore, so I refer to this, one of the concepts that I try to get across is how the process of developing scientific knowledge works, including in medicine. So the process of scientific knowledge is that you make a hypothesis, you assume your hypothesis is wrong until you can find evidence to prove that your hypothesis is right. You don't do it the other way around. You don't assume your hypothesis is right and then try and find evidence to disprove it. That's upside down science. But unfortunately, that's what's been happening. So this is called the null hypothesis. You assume the null hypothesis, in other words, your hypothesis isn't true to be true. And I go through the evidence on genetics, on neuroimaging, on chemical imbalances for autism, ADHD, and on these three areas. And I try to demonstrate that the null hypothesis holds in each of them. In other words, we haven't come anywhere near to showing that these are genetic, that there is specific brain differences or abnormalities that are measurable and replicatable. And we haven't shown that there's any specific or measurable chemical imbalances either. So that whole area is an empty cupboard of evidence.
Wow, very, very interesting. Are you still a practicing doctor?
I retired just a couple of months, just 3 months ago.
And what's the trend? Yeah.
I might be, and I worked in public health services my whole career. I might be dipping my toe into some private work in the near future. We'll see.
So what was the trend when before you retired? Do people want their children to be diagnosed with something? Are they eager, adamant? Do they demand? Like what's going on in the UK? I'm really curious about that. And did you diagnose people with autism, ADHD? What was your work? What did your work entail? Do you prescribe medication? Is it different than the United States? What do you know about that?
One of the things that I tried to do is, as far as possible, I tried to shy away from going down the route of diagnosis. This was much easier with patients who I was the first person to be considering that. I was a consultant to a team, so I did get a lot of patients who were being seen by other people. I got a lot of people who had had several interventions by other professionals. I was getting an increasing number of people who were thinking, and understandably thinking so, that maybe their child has this or that condition, because that's the narrative around us. Teachers would be suggesting that, other parents, other children. This kind of idea of mental health awareness has spread and sensitized people to an idea that there might be something wrong in them. So a lot of adolescents started imagining that they were having this or that condition. It certainly accelerated that trend after we were coming out from COVID lockdowns. That was a big event that caused an acceleration of this trend. And I was quite open with people, and I did explain that in psychiatry, diagnoses don't work in the same way as in a lot of rest of medicine. And I explained that I can't do a blood test, I can't do a brain scan, and I can't examine your thoughts under a microscope. It's that what you get is opinions, and that these diagnoses don't really tell you much about what's going on, and they actually don't tell you much about what might be helpful. And that's something that we have to figure out together. And actually, most people tend to understand that. There were some people who were very adamant, and those who were very adamant, I would try and help them through that process. So I would explain to them the criteria and what sort of behaviors. And one of the things that I was really trying hard to help people keep in mind is that any of these diagnoses, they are not lifelong. They don't define you. And that the one constant about growing up is change, and that you will change. And one of the advantages I had is a long time working in this is that I can tell them about people I've seen, because I've seen people who have been in the worst bit of functioning, really disabled by their mental health difficulty. I've seen people who've been in and out of inpatient units, been prescribed all sorts of medications, gone for therapy after therapy after therapy. I can tell them, in my experience, at some point, I don't know when, I don't know what the trigger will be, but I've seen it again and again and again. At some point, something will click, and you will understand what I'm trying to tell you. Because a lot of the time I was trying to help people change their relationship to their mode of distress. Instead of seeing it as something that they had to defeat, that they had to control, that they had to suppress, that they had to get rid of, I see suffering as loaded with meaning and loaded with things that actually might be developmentally important, and not to dismiss that. And a lot of the time it was about how you learn to live alongside these distressing experiences. And that included working with people who were psychotic. I had quite a few I've seen quite a few people who are, some people are in the situation where they're no longer able to hold some sort of coherent conversation, and they might be in very dangerous states of mind. So, of course, there are occasions where you are thinking, okay, we might need medication for a period of time. We might even need to consider an inpatient unit for your safety and for other people's safety. So I'm not averse to that at all. But there were quite a few people I saw over the years with these psychotic presentations who did not require medication. Maybe they required something to help them sleep for a short period of time, to help bring their arousal levels down. But it was working on helping them give meaning to, because their psychotic experiences are often intensely meaningful, and they're often related to things that have happened in their life. People who tend to come to our clinics tended to be people who've had a lot of adversity. I mean, I'm sure you've found that in your clinical work. The way we're built as human beings, when bad things happen to us, we feel bad, and we feel bad in all sorts of different ways. So I'm trying to bring that back into the sphere of something that's not to do with a broken brain. I spent a lot of time trying to notice and help people notice their own capacity. Some of the most resilient people I've seen are the people who've come to our clinics, being able to still function at some level despite how terrible you feel. So there are all of these things that if you miss them and just go down the route of seeing them as having some sort of broken brain that will be fixable by some technical fix, you can miss the opportunities to empower people to understand or reach a different way of understanding their distress and learning how to live alongside distress. Suffering, I sometimes tell the young people I see and the parents of the young people I see, I really, really hope that reincarnation isn't real, because I'd hate to go through my adolescence again, you know? It's tough growing up, and we shouldn't try and pretend otherwise. And we shouldn't try and convince young people that sometimes you have to live through these things and you will come out of the other side. And I've seen it again and again. I've seen people recover from the worst situations. The one medication which we do get a lot of pressure to prescribe is antidepressants these days, even though the evidence says that these don't make a difference compared to a placebo in clinical trials, and they have an increased likelihood of people experiencing suicidal impulses. And that's been my clinical experience. So I do tell people, look, my clinical experience and the evidence is that I have yet to come across one person in my 3 decades of work, and I've been an inpatient, outpatient, I've done all sorts of different services in my career. I've yet to come across one young person in which an antidepressant, an SSRI antidepressant, leads to lasting improvement. I see some people who have that, what I call an enhanced placebo phase, and then after a few months it starts to wear off and they start to think, I need a higher dose, or maybe I need to try a different one. So sometimes I do prescribe, but it's prescribing because the people I'm seeing want to try it, even though I've told them that. And I say, okay, we'll try this. But if you feel a little bit better, this is your window of opportunity. So, and it's what you do in that window of opportunity that will make the long-term change. Because remember, a drug doesn't have a thought. A drug doesn't make a decision. So if you do feel a little bit better, what are you going to do? So I only prescribe if we have a plan about what they're going to do if they start to feel a little bit better. So and I explain, it is not the treatment. When you give people painkillers for because they've hurt their knee, the painkiller is not the treatment. The knee getting better is going to be physiotherapy and other things to rebuild, the strength in that knee. And the painkiller might help you for a while for you to be able to do these things. So I kind of use these types of metaphors.
Yeah, that's very helpful. It was quite interesting to read in the book about other countries, like, and how the historical, it was Latvia, like the Nervi, because I grew up in the Soviet Union. Yeah, I remember, like, so much has changed, right, in so many decades. But how people used to talk about those conditions and how far we've come, and you culturally, you say that you speak Arabic. Like, what is your background, and do you think that plays a role in how you think about those things differently? I want to hear a little bit about that.
I think it has played a role. In my earlier life in Iraq, and so I was exposed to a very different way of understanding the world. And I had some very religious cousins who I was very close to. I had parents who were skeptical of religion. So, from early on in my life, I had these contrasting views about how to understand the world and how to make sense. And then I ended up in the UK because my mother's English, and we were sent to the UK, myself and my older brother, because of a deteriorating political situation, and the war with Iran was around the corner, and military conscription age was coming up. And it was quite a culture shock, because the sort of unwritten rules, I was 14 at the time, the unwritten rules about how a 14-year-old was meant to behave in Iraq compared to in the UK, it was just very different. So I think I was sensitized quite early on to this idea. And going through then my psychiatry and also my psychotherapy trainings, I realized a lot of the literature was, and I used to go along with this to start with before I began asking deeper questions. It painted the culture that I came from as being primitive, as being loaded with superstition, as not being psychologically minded. There was this kind of colonial hierarchy that was embedded in the way we think about other cultures, that we've got it right and the other culture's way of. So I think all of those experiences did sensitize me into asking questions, and also finding it hard to settle on an idea that this group knows the truth. And this is, so I think that maybe trained me into critical thinking, into asking questions. And of course, the Nervi example of what happened in Latvia is quite instructive of, because, as you will know, dramatic changes took place across Eastern Europe with the kind of shock and awe method of bringing capitalism into societies that were trained in a more collectivist way of thinking, and imposing a new way of understanding distress. And one of the things that I also became aware of, because I've had ongoing contacts with people from an Arabic background who either came to this country or still are in Iraq, is that there is and of course Iraq was a colony of the British, so I'm living in the kind of colonial motherland, if you like. For a lot of people in Iraq, there was a sense that all the good things and all the modern and fancy ideas, they come from the West, and the West has sort of kept them to themselves. So there was a kind of envy in there. So there was a mixture of a dislike for what was done and a quiet admiration of wanting to be like them. You'll only make it if you want. Books that really describe that psychological process really well is I think I quoted, is Frantz Fanon, who was who wrote two really good books, one called Black Skins, White Masks, and the other, The Wretched of the Earth, which is about the psychological impact of colonialism, where you feel the person is superior. It creates this kind of superiority, inferiority. and the kind of violent effects of trying to combat. So this colonial export of ways of thinking about mental distress that's been developed in the West is something that I try to address in my book, because it's gone worldwide. These concepts have been taking off worldwide and creating markets worldwide.
You know, my daughter is American. You know, I'm married to an American and I'm Armenian. So I came to the United States when I was 27. So my development happened in Armenia. And I've been through a lot of adversity and trauma. And I am a very resilient, resourceful, capable, highly capable individual. I never struggled with mental health, never took medication, never was diagnosed with anything. You know, that was the norm, right? You live through experiences, you grow and you change. And some people don't, some people do to various degrees, right? So, what I'm noticing here when my daughter socializes with my side of the family, now that she is a teenager, she sees differences in the Armenian way of living and being in the American. And she always comments, she says, wow, mom, you're part of the family, your brothers, your cousins, everybody's so resilient. The way they talk, their mindset, what they achieve, how they approach life and the challenges. She notices the differences. Whereas she says, this side of the family, the American, she says they all try to focus on, oh, you experienced that, like, poor you. She says there's no encouragement. There's no, you got this. You can get things done. Come on. I mean, apply yourself. She notices the difference. And I think that that's striking how being part of these two cultures, she identifies. But I can see oftentimes when she experiences challenges, first world problems, where is my Amazon order? It didn't come. It was supposed to come. Where is it? That can turn into a big disaster. Children this day, right? One child gets up and says, I want to have avocado toast. And they happen to have no avocados at home. The child throws a big, temper tantrum and kicking and screaming. I want avocado toast. I wanted to eat it. I was craving it.
That's because they have PDA and that's a meltdown.
And that's where they have PDA. And so that's a problem. Like we who saw adversity, I saw hunger, I saw homelessness, I experienced so much that I don't understand what's happening today when children, they don't even have, forget the resilience, they don't even have tolerance for simple challenges. And we cave in and we give in, we make their lives magical and perfect, we cater, we lower the demands. And there is a big cost to that.
There is a big cost to that.
It's the mental health that's going to come in the future. We are actually digging bigger holes.
You undermine, because one of the things that I feel quite strongly is that resilience is not something you can be taught.
Yes.
You have to discover it.
Yeah.
You can only discover it if you're allowed to discover it. There's a really nice paper written by a colleague mine and who I'm lucky enough to call a friend. He's a child psychiatrist in Australia. His name is John Uridini. And he wrote a paper with the title, Let the Children Cry. And the basics of his paper was saying that our role as parents is not to rescue our children, is not to make it possible for them to avoid suffering. That's a very unrealistic and actually unhelpful. Our role is to be there when they do, when they struggle, to help them understand that these are survivable. That's how you develop psychologically. That's how you deepen.
That's how you develop psychological resilience, adaptability. And what are the struggles, in the modern world? Like we experience struggles. What are the modern day struggles for the kids? My iPad is not working. My Nintendo Switch broke. I don't want to have pancakes for breakfast. I want to have whatever. What are the problems? They don't have real struggles, right? Because our life is decent. We have conveniences, we have luxuries, we have heat, we have food, abundance of things. And so there aren't real external.
These are not existential struggles.
These are not existential struggles. And so the struggles they experience, we try to prevent or minimize and rescue. And so what's there left for them? Like, where is the space for them to grow and develop resilience and self-competence, right? Because when you overcome something, your competence rises. And it's just like, it's amazing of what I see in the United States these days.
This is why you might have noticed that I have a lot of time for Gabor Mate. I think he's an excellent analyst, a great teacher, really compassionate and kind, humane. But I think there is this idea of trauma, which I have been critiquing, because I think trauma is, again, another of these subjective things. And it's another of these concepts that has expanded. And it's part of this whole developmental phase where we imagine there are technical ways of avoiding adversity in our lives so that we can fix all sorts of things to eliminate any source of suffering. But actually, how can you experience joy if you don't experience sadness? Isn't there a kind of a dialectic to all our emotional experiences? We have to have suffering.
We have to. There's a wonderful quote by Khalil Gibran. I think I saved it in my phone about that. Let me see if I can find it about, how your heart grows if you experience sorrow. And that's why, like, I'm the happiest person. People are like, how come you're always so happy and joyful? Because I experienced a lot of pain and suffering. It's dialectical. I mean, I'm laughing, but where are my quotes? I found my quotes. It's so I found a quote, sorry to cut you off. Joy can only fill your heart as deep as sorrow carves it out. Isn't this beautiful? Khalil Gibran. Yeah, I saved that in my phone. I remember that. I don't know by heart, but it's a good one. Yeah. So what is your final message? How do we end this conversation today? What is your do you have a direct message to the listener, to the parent of this podcast?
It's hard to distill things into a single message. And of course, everybody's situation is different. And I don't want to sound like I'm romanticizing suffering. Suffering is, there are degrees of suffering, of course, But some of the, if you like, tips that I would say that might be helpful for you to keep in mind. The first one is don't try too hard. I think we try too hard to fix things for our kids. If what I say to parents is, I think most parents feel guilty most of the time these days. There's so many ways in which we've been talking to parents to say that this could happen, that could happen. So parents are full of worry about their kids and full of worry that they're not doing enough, they're doing too much, they should be seeing somebody, they shouldn't be seeing, and so on and so forth. And they just get these messages all the time. And the trouble with is you can't solve that guilt. At least you can try not to be driven by that guilt to try too hard and end up in the process of trying to fix what you imagine are things that you need to fix in your kid instead of just letting them develop in their own way, is that you'll end up by accident turning them into a patient rather than a kid growing up. So don't try too hard. Let things happen. The second message I would say is don't be afraid of emotions. I think we've got a war on emotions going on at the moment. This is your example about kids in preschool losing their temper. That's what kids do. Don't be afraid of emotions. Kids experience their emotions. They're not adults. They're not in a position to think through what they're doing. They will just react. Don't be afraid of that. That's the way we're built. That's part of development. So don't be afraid of emotions. Don't be afraid of your own emotions. Don't imagine your emotions are things to be fixed. Don't transport or transfer management of the emotions of your kid to professionals. You've got the biggest role in helping them through. So don't be afraid of your kids' emotions. And my final one is beware of concept creep. So concept creep is we've become more and more likely to use psychotherapy and psychiatry and medicalized language to describe all sorts of things. So kids don't have tantrums anymore. They have meltdowns. No, and that's a word taken from the sort of autism idea.
But they're dysregulated. I use that too. So
Yeah, don't dysregulated. Who's regulating? What is the regulation? It makes it sound like there's some big brother in our minds regulating. So yeah, you don't need to talk about depression. You don't need to talk about having anxiety. Kids get scared. Kids get worried. Beware of these concepts. You don't need to talk about kids being traumatized and things. All of these kind of languages that have crept in. Overthinking, masking. Take them out. Masking is what we teach children. It's not a sign of something wrong with, Of course, I want my kids as they grew up to have some sense of how they behave in social situations. I don't expect them to behave in social situations they were behaving at home. Of course, you teach masking. So beware of these concepts that are coming from, the world that we're sort of a part of, and keep things in the realm of the ordinary and or understandable.
Excellent. Thank you. Thank you.
Those are my little tips.
Well, and I want to end by saying, I work with co-parents, divorced couples. I do co-parenting counseling. And another newest trend these days is I have this 3-question calendar on my website. When people book to speak with me, I ask them a few questions, and almost every time everybody fills the questions like this. I am dealing with a narcissist and I'm in a high conflict co-parenting. So everything is high conflict and everybody is a narcissist. So there you go. Another term.
Yeah.
Two other terms.
There's another concept creep. Yeah. Narcissist is everywhere now, isn't it?
Everybody's a narcissist. I don't know who are the rest of the people then, right? Where are
gaslighting? That's another one. That's
yes, gaslighting. Don't gaslight us, Dr. Tamimi. Well, thank you so much. It was enjoyable. I hope it will be received by the listeners the way we intended this message to land. I enjoyed reading your book. It's quite provocative. You question things, and I enjoyed having you on the podcast. Thank you so much.
Oh, thank you so much, Anna, for inviting me. I've enjoyed our conversation too.
That concludes today's conversation, my dear listener, and I hope you found this episode helpful and inspiring. Be sure to hit that follow button so you don't miss future episodes, and take a moment to leave a rating and review. It really helps others find the show. I would love to hear your thoughts and takeaways. Join the conversation in the Authentic Parenting Facebook group or visit the contact page at authenticparenting.com/contact to get in touch. Authentic Parenting is an ad-free show, and your donations is what makes this podcast possible. Support the show by visiting authenticparenting.com/support or becoming a patron at patreon.com. Your contributions make it possible for me to continue bringing you weekly episodes. And as always, connect to the present moment, to yourself and your children. Until next week, I am Anna Seawold. Thank you so much for listening. This episode was edited and produced by Ami Noor. If you need expert support to bring your dream podcast to life, from editing to full production, Aminur can help make it happen. You'll find his link in the show notes.